Welcome to this explainer. Today, we're diving straight into the fascinating, microscopic origins of some rare gastrointestinal tumors. We'll be looking at how seemingly ordinary symptoms can actually be the first clue to some truly incredible cellular biology.
Let's kick things off with a case study. Imagine a 60-year-old woman, we'll call her Mary. She comes into the clinic complaining of recurrent nagging stomach pain. An endoscopy is performed and it reveals a 3-centimeter gastric ulcer with elevated borders. Now, Mary just talked she had a simple stomachache, but her biopsy revealed an incredible pathology. This wasn't your standard run-of-the-mill ulcer. It was a low-grade MALT lymphoma. And here is the absolutely crucial detail. She tested positive for the bacteria H. pylori. Mary's case perfectly illustrates a massive, high-yield concept, especially if you're prepping for medical licensing exams, how a simple bacterial infection can literally drive the formation of a malignant cancer.
To really wrap our heads around these complex pathologies, we're going to break down 3 distinct GI tumors by anchoring them directly to their unique cellular origins: MALT lymphoma, GIST, and finally, neuroendocrine neoplasms. All right, first up, MALT lymphoma. Let's track exactly how the immune system's mucosa-associated lymphoid tissue essentially becomes a staging ground for cancer. So under normal physiological conditions, your stomach lining doesn't even have lymphoid tissue. It just doesn't belong there. But when you introduce an H. pylori infection, that bacteria provides continuous, nonstop antigens. This puts the immune system in overdrive, triggering T cells and causing B cells to chronically multiply. Because of this, lymphoid follicles are practically forced to form abnormally, right there in the stomach mucosa. Over time, this persistent inflammation and constant antigenic stimulation can actually evolve into a monoclonal lymphoma. Now, here is a remarkably cool fact you absolutely need to remember. This particular lymphoma can often be cured just by getting rid of the bacteria. Literally, treating the H. pylori with standard antibiotics, like amoxicillin and chlorothromycin, leads to complete tumor regression in over 75% of cases. That is a huge takeaway. So what is happening at the genetic level when that chronic inflammation sticks around too long? Well, in up to 50% of gastric MALT lymphomas, there is a very characteristic genetic defect, the T1118 translocation. This essentially takes the BIRC3 gene on chromosome 11, which normally acts as a brake to stop cell death, and fuses it with the MALT1 gene on chromosome 18. This abnormal fusion permanently flips the switch on a pathway called nuclear factor kappa B, or NF-kappa B. This is like a broken signal that tells the B cells to constantly multiply and perfectly blocks their natural ability to die off. They just keep replicating. If you were to look at this under a microscope, there is a classic hallmark, a massive pathology buzzword you've got to know. You'd see something called lymphoepithelial lesions. This is basically clusters of these neoplastic lymphoid cells aggressively invading and completely destroying the normal gastric glands, causing the epithelial cells to break down. And when you stain the tissue, these cells light up intensely for the CD20 surface marker. That intense positive staining is the definitive proof that you are dealing with mature B cells. Now, gastric MALT is the classic example, but you also need to be familiar with its small intestine counterpart, known as IPSID, which stands for immunoproliferative small intestinal disease. There are some fascinating differences here. While gastric MALT is triggered by H. pylori in the stomach, IPSID is triggered by a totally different bug, Campylobacter jejuni, a gram-negative microaerophilic bacteria that sets up shop in the upper jejunum and duodenum. Clinically, a patient with IPSID is going to present quite differently. They'll come in with severe malabsorption, diarrhea, and low protein levels. And diagnostically, up to 90% of IPSID cases will actually show elevated levels of abnormal, truncated alpha-heavy chain monoclonal proteins in the blood, completely lacking their partner light chains. Okay, moving right along to our second category, GIST, or gastrointestinal stromal tumors. Let's shift our focus deep into the muscular wall of the gut. Unlike MALT lymphomas, which obviously come from immune cells, GISTs originate from a truly fascinating cell type, the interstitial cells of Cajal. These cells are derived from the mesoderm, and you can think of them as the literal electrical pacemakers of your digestive tract. They live within the muscularis propria and generate spontaneous electrical impulses. These signals then spread to the surrounding smooth muscle cells, creating those rhythmic peristaltic contractions that keep food moving through our system. To understand how to treat a GIST, you have to understand the molecular driver behind it.
Normal interstitial cells of Cajal have a specific receptor on their surface called the c-KIT receptor tyrosine kinase. Well, in about 80% of GISTs, there is a gain-of-function mutation in that c-KIT gene. This means the receptor gets stuck in the on position. It doesn't even need its natural trigger, the stem cell factor, to activate. It just fires continuously, acting like a stuck accelerator pedal for cellular growth. Another 8% or so of GISTs have a nearly identical mutation, but in a related receptor called PDGFRA, which ultimately triggers the exact same hyperactive growth signals.
When examining the tissue morphology, you'll find that about 70% of these tumors are made up of really bland, spindle-shaped cells arranged in these short little bundles or whorls. Another 20% fall into the epithelioid subtype, where the cells are rounder and grouped together in nests. But the absolute most important diagnostic key here is the immunohistochemistry. These cells will show diffuse, intense cytoplasmic staining for that exact KIT protein we just talked about, which is also known as CD117. Finding that CD117 positivity is an incredibly specific and sensitive way to lock in the diagnosis. And knowing about that CKIT mutation brings us to a literal game changer in oncology. Because we know exactly what mutated receptor is driving the tumor, we don't have to rely on traditional chemotherapy, which, by the way, provides almost zero benefit for GISTs anyway. Instead, we use targeted therapies like imatinib. Imatinib is a specific tyrosine kinase inhibitor that goes in and directly blocks those hyperactive receptors. Today, it is the absolute gold standard treatment for patients dealing with metastatic or unresectable disease. Finally, let's jump into our third category, neuroendocrine neoplasms, or NENs. The cells that cause these act as a bridge, converting electrical nerve signals into hormonal signals by releasing various amines and peptides. When it comes to the WHO classification for well-differentiated neuroendocrine tumors, it all comes down to speed, specifically how fast are the cells dividing. We track this using two heavily tested metrics, the mitotic count and the K67 proliferation index. Grade 1 tumors are very slow-growing, showing a mitotic count of less than 2 and a K67 index under 3%. Grade 2 is your middle ground, but grade 3 tumors, those are highly proliferative and aggressive, with greater than 20 mitoses and a K67 index skyrocketing over 20%. Macroscopically, these tumors usually present as these firm, yellowish nodular masses growing deep beneath an intact mucosal lining. But microscopically, there is a classic pathology buzzword you simply have to memorize: salt and pepper chromatin. The nuclei of these cells have this distinct speckled appearance, surrounded by a granular pink cytoplasm. You'll often see them arranged in really neat architectural patterns, like little nests or long trabecular ribbons. Now, it is absolutely vital that you can distinguish those slow-growing, well-differentiated NETs from the poorly differentiated neuroendocrine carcinomas, or NECs. Well-differentiated NETs are generally indolent. They form nice, intact nodular masses and honestly have a better prognosis than standard adenocarcinomas. Poorly differentiated NECs, on the other hand, are highly aggressive beasts. They form massive, ulcerated lesions and are notorious for early, widespread metastases. In fact, their behavior and appearance are strikingly similar to small cell or large cell carcinomas of the lung. When you look at the poorly differentiated carcinomas, all those neat little nests and ribbons we just talked about are completely gone. The architecture is totally lost. Instead, you just see chaotic, sprawling sheets of hyperchromatic cells with barely any cytoplasm. And another massive red flag for these high-grade carcinomas is the presence of extensive necrosis. Literally, areas of dead tissue tearing right through the tumor structure. All right, let's talk about a major clinical presentation you absolutely must be familiar with: carcinoid syndrome. So neuroendocrine tumors in the small intestine love to secrete hormones like serotonin and histamine. Normally, this isn't a huge problem systemically because the blood from the gut goes straight to the liver, and the liver quickly metabolizes and inactivates these hormones. But if that tumor metastasizes to the liver itself, suddenly those hormones are being dumped directly into the systemic bloodstream, completely bypassing the liver's filtration system. This massive dump of serotonin triggers the classic triad of carcinoid syndrome: severe skin flushing, chronic watery diarrhea, and right-sided valvular heart disease, along with bronchospasms. To diagnose this, we look for a huge spike in urinary 5-HIA, which is simply the metabolic breakdown product of all that excess serotonin. To really nail down the diagnosis for these neoplasms, we rely on specific biomarkers. Under the microscope, tissue stains for chromogranin and synaptophysin are your absolute go-to markers to prove a tumor has a neuroendocrine origin. But a quick word of warning on blood tests. While a serum test for circulating chromogranin is highly sensitive, it severely lacks specificity. Why? Because incredibly common, everyday things can cause major false positives. For instance, if a patient is simply taking proton pump inhibitors for heartburn, or if they have underlying hypertension or kidney disease, their serum chromogranin levels will be artificially elevated even if they don't have a tumor at all.
So, looking at the big picture, knowing the distinct cellular origins of these rare tumors really begs a critical question. As we continue to decode these specific molecular defects, whether it's an H. pylori bacterial trigger in MALT lymphoma, a sick-kit pacemaker mutation in GIST, or the rogue hormone-producing cells of a neuroendocrine tumor, how will matching these unique molecular signatures to targeted therapies completely redefine our pursuit of an ultimate cure? Understanding the disease at the cellular level is just the first step to conquering it entirely. Thank you so much for joining me on this explainer, and keep exploring these incredible pathologies.